Good afternoon, everyone. I'm Dr. John Pearce, postdoctoral researcher with the Aphasia CRE, and I have the privilege today of introducing Dr. Maya Menahemi Falkov. But before I do that, just going to cover a few things. First of all, I'd like to acknowledge the traditional owners of the lands across Australia and pay my respects to elders past, present, and emerging. Today, I'm joining you from Boonwurrung country, and I extend that respect to all Aboriginal and Torres Strait Islander people with us today. So Dr. Menahemi Falkov will be sharing her presentation, No Gains Left Behind, What SLPs Need to Know About Maintenance in Chronic Aphasia. A quick reminder before we begin, if you do have a question, please type it into that Q&A box at the bottom of your screen at any point in the presentation. So you can add your thoughts as they come up, and if you see another question you'd like answered, please feel free to upvote that question, and we'll aim to cover as many as we can during the discussion at the end. So it's my great pleasure to introduce Maya. Dr. Maya Menahemi Falkov is a senior speech pathologist, allied health leader, researcher, and university lecturer with over 20 years' experience leading speech pathology and audiology services in major tertiary hospitals. She has driven service redesigns and pioneered digital health innovations, including telerehabilitation delivery models. Maya has lectured at La Trobe, Tel Aviv, and Haifa universities. Maya's research grows directly from clinical practice with a focus on connecting evidence to real-world service delivery. She completed her PhD at the Aphasia CRE, addressing a critical clinical question: what factors determine whether communication improvements are maintained after intensive aphasia therapy ends? Her work pioneered the use of minimal detectable change methodology for evaluating individual therapy success in aphasia, and this approach is now used in international clinical trials and has informed international guidelines on measuring treatment success. Maya continues to translate research into sustainable practice, helping ensure people with aphasia receive care that delivers lasting outcomes. Please join me in welcoming Dr. Menahemi Falkov.
Thank you, John. Thank you for the lovely introduction. And let me share my screen. Okay.
Looks good, thank you.
Okay, great. Let's see that. Okay, so good afternoon, everyone, and thank you for joining. And the title you see on the screen, No Gains Left Behind, reflects the importance of understanding why aphasia therapy gains may decline and what we can do to keep them for the long term. So let me start with Mike, whose partner has chronic aphasia. I've got no skills to maintain, to keep that going. So you fall back into the ways you were before. That line captures a critical gap, maintaining gains over time. Aphasia therapy works, but the real challenge is the long-term maintenance. Today I'll share findings from my PhD. How many actually maintain their gains? How to measure therapy success at the individual level? What influences maintenance, barriers, and enablers? How to better support long-term maintenance because no gains should be left behind. And over the next 45 minutes, I will present key insights. We'll explore 5 core areas: acquisition versus maintenance, the shift towards individual level evaluation, barriers to maintain gains, and the critical transition from external motivation to habit formation. And finally, what we can do to actually help, and of course, call for new models of care. And before we dive into the research, I want to take a moment to establish why I'm speaking about maintenance, why it's so important. Maintenance isn't what happens after therapy. It's what therapy is for. We often think of clinical effectiveness as producing gains. But true effectiveness requires both strong acquisition and long-term maintenance. Without maintenance, even our strongest treatment effects lose their value, both clinically and economically. Aphasia rehabilitation relies on learning and relearning. Learning means relatively permanent changes, changes that support long-term retention and transfer. And this is especially critical in people with chronic aphasia. Beyond 6 months post-stroke, the brain's spontaneous recovery processes have diminished, and at this stage, people are unlikely to benefit from further spontaneous recovery. So improvement and maintenance depend almost entirely on intentional learning and ongoing skill use. This is why we need to distinguish: are we measuring temporary performance or true learning? In therapy, we often focus on performance, what people can do during or right after treatment. We see immediate gains, but there is a critical difference between performance and retention or maintenance. Performance is temporary. Retention is what actually sticks for long term. And the big question, do those gains last weeks, months, or years after therapy ends? Unfortunately, they often don't. And here's the challenge. The cognitive psychology literature shows us performance improvement during therapy do not automatically guarantee long-term retention. Intensive practice can rapidly boost short-term performance, but without additional intervention or continued use, those gains are at high risk to decline. Unfortunately, behavioral change is highly challenging to maintain, and loss of gains is common in both normal and brain damaged population. At the starting point of this work, we knew very little about the maintenance of gains in people with aphasia. So we looked into the aphasia literature to see what evidence exists. Interesting results regarding long-term maintenance were reported in the 2016 Cochrane review about people with aphasia. It found immediate post-therapy benefits in speech and language compared to no therapy. However, these gains were not maintained at the 6 months follow-up, so it was unclear how long this improvement may last. Our work focused on intensive aphasia therapy programs. There is no clear agreed definition for intensive therapy. It often defined as 5 minimum of hours per week, with some programs exceeding 20 hours. Intensive aphasia programs are considered best practice for post-stroke aphasia based on evidence from high-quality research such as RCTs. This project began from a clear gap in the literature. While we knew a lot about achieving therapy gains, the questions of long-term maintenance in chronic aphasia was significantly under-researched. And this left us with a series of fundamental questions to address. We wanted to know, what is maintenance? How much improvement is considered significant for the individual client? Are treatment results maintained? Is treatment effective for everyone? And what factors impact maintenance? Study 1 explored the evidence concerning the long-term maintenance following intensive aphasia interventions in chronic aphasia. In our systematic review, we were interested to know, for post-stroke chronic aphasia, what impairment, activity participation, quality of life outcomes are maintained following intensive aphasia treatments. We included behavioral interventions that delivered at least 5 therapy hours per week for post-stroke chronic aphasia. We initially found 104 intensive aphasia intervention studies, which matched our criteria. Of these, only 42% actually included any follow-up data point. So we can see that follow-up evaluation in the aphasia literature is not that common. RCTs are the gold standard for evaluating interventions, but they focus on group-level effects. Group averages combine data from all participants, often masking individual differences. A few strong responders may lift the mean, while others show little or no change. To address this, we analyze the data differently. Instead of reporting group averages, we used a simple method commonly applied in health research, reporting on proportions of treatment responders. This method highlights the percentage of clients who truly improved, offering a clearer, clinically meaningful picture. Earlier aphasia reviews rarely applied this approach. Before reporting response rates, we had to define what counts as significant improvement for the individual for each outcome measure. To identify true responders, we need to separate real change from measurement error, and every test you use, every test score includes both. The minimal detectable change, MDC90, gives us a benchmark, a threshold for significant improvement. Scores above the benchmark reflect real change. Scores below are likely just a noise or measurement error. This approach helps us reliably identify who truly improved across different studies. Here are the MDC benchmarks for 6 outcome measures in chronic aphasia. These benchmarks are clinically useful. You could apply them in practice tomorrow, but keep in mind, different benchmarks are needed for acute, subacute stages, and other languages. With these methods in place, what did we actually find? Let's look at the results, using individual level analysis to reveal who truly benefited. At the group level, intensive aphasia therapy is effective. Most studies reported statistically significant immediate gains and maintenance. But when we look at the individual level, the picture changes. Only about 1/3 of participants showed a significant immediate improvement. This gap between group and individual results likely reflects few strong responders lifting the average, while many others showed little or no benefit. And even among those who improved initially, many didn't maintain their gains. Between 1/3 and 1/2 of immediate responders lost their progress within 3 to 6 months post-therapy. In total, only 22% of participants in group studies maintained their gains over time. That's just 1 in 5. The rest either showed no meaningful improvement during therapy or lost their gains by follow-up. The review gave us 3 clear messages. Group averages aren't enough. We need to understand how individuals respond. Maintenance matters. Therapy success means keeping the gains, not just making them. And long-term effort is essential. Without it, progress may fade. And these individual results force us to rethink what is maintenance. Traditionally, maintenance was treated as passive neuroplastic stability. If the brain holds a change, gains persist. But our findings suggest otherwise. Maintenance is an active process and requires continued use or effort. The principle is simple. You all know it. Use it or lose it. The key question is what supports ongoing use in real life. Understanding what supports maintenance is essential for lasting outcomes, evidence-based practice, and real-life success. Yet we knew surprisingly little about what happens after discharge. So we conducted 2 studies to shift the focus from what happens to why it happens. Study 1 showed us what happens by mapping the patterns of decline in a systematic review. Studies 2 and 3 asked why. We listened to lived experiences, barriers, enablers, and what we can do. Here you can see the 2 qualitative publications that explored maintenance from clinician and clients' perspectives. Let's hear decline in their voices, not just charts. Aaron told us, I do feel there has been a decline since he stopped his speech therapy. Another partner said, things might have faded. It doesn't sort of stick in the brain. Our research asked, what influences maintenance of therapy gains? What are the barriers and enablers? We explored this from 3 perspectives. Clinicians' experience in chronic aphasia rehabilitation, people with chronic aphasia, and their partners. We interviewed 7 SLPs and 8 people with aphasia and their partners. You can see the participants' demographics on the slide. We conducted semi-structured interviews. We used thematic analysis to understand their experiences. The aim was to generate rich person-centered insights. Let's see, what did they tell us? As we delve into the data, we found significant overlap across our main themes. For the sake of time today, I will be presenting a high-level summary of these integrated findings. On this slide, we see that people with chronic aphasia, their partners and SLPs, all pointed out to 4 shared factors that influence whether therapy gains are maintained. Engagement in real-life communication, gaps in knowledge and available services, personal abilities, and external support. SLPs also focused on setting meaningful goals and the challenge of turning them into real-life participation. People with aphasia and partners spoke about beliefs around progress, decline, and what maintenance really means. Each bring different lens, clinical versus lived. In therapy, we often treat behavioral change as a single process, but research tells a different story. Starting a change and sustaining it are 2 different challenges. Initiation is usually driven by external motivation, structure, support, feedback from clinician, or visible progress. Maintenance relies on internal drivers, motivation, self-regulation, habits, and ongoing support. It also depends on real-life opportunities to use communication in daily life. Without this, even successful therapy gains are at risk. So, what is the key to maintaining gains? Across our studies, a clear consensus emerged. People who engage in daily, real-life communication, despite their disability, tend to better maintain gains. SLP in our studies were clear. Maintenance isn't about drills. What matters is using language in real life. The goal shifts from improving language to using it consistently. And what makes communication sustainable? Activities that feel good, that are personally meaningful. Things people already love, part of daily routines, social life, hobbies, life roles, and providing a source of connection. When communication is embedded in everyday routines, it doesn't just maintain language, it improves motivation, well-being, and connection. As one SLP puts it, if you want to improve conversation, you have to practice talking. If you don't keep doing it, you won't maintain that. In other words, Real-life communication is the therapy. Real-life communication can be the therapy, but only when people have opportunities to use it. And here is the paradox. People with aphasia often lack those opportunities. Prior research and our interview show the problem clearly. Fewer social interaction, smaller networks, and limited access to suitable environments. When you add the cognitive demands and emotional toll, staying engaged every day becomes very difficult. Without professional guidance, many clients return to familiar impairment drills, safe, but less related to everyday communication needs. Meanwhile, daily moments like ordering coffee, calling a friend, chatting on a walk often go unnoticed and unpracticed. SLPs in our study expressed concern. Clients rarely recognized daily interaction as communication opportunities, yet these are the moments that matter most. As SLP Alice noted, my role is to give them opportunities because this is what they don't have. Communication opportunities are key to maintenance. Without them, gains often fade. We need meaningful activities, not just aphasia groups, but hobbies, routines, and social roles that matter. Yet finding these opportunities alone is extremely difficult. And that is where goal settings comes in. Research shows that when people feel passionate about their goals, they show greater self-efficacy, effort, and commitment, all of which support goal achievement. But what does this look in the real life? Let's hear what participants had to say. People with aphasia need a reason to keep going. They need a direction. That is where meaningful real-life goals come in. SLP told us that for the goal to be effective, it must come from the client, rooted in what the person cares about. Not just language goals, but goals that reflect their values, roles, and identity to drive motivation after therapy ends. Kate, a person with aphasia, put it perfectly. Couple therapy is still my passion, absolutely. What I'd like is to talk well enough to work with couple therapy with aphasia. This is internal motivation. When a goal reflects who you are and what you care about, motivation doesn't end with therapy. You keep trying, not because someone told you to, but because it's tied to your identity. Many SLPs identified key challenges, setting meaningful goals and turning them into real-life participation. The first challenge was defining a meaningful goal. People with aphasia struggle to define goals, or they aim for unrealistic ones like back to normal. There was often little time to explore what truly matters, and when others suggested goals, they can lose personal meaning. The other challenge was turning goal into action. Real life is messy and unstructured. This makes it hard to track progress or know when a goal has been achieved. Sarah raises a key point. When it's not structured, people don't really have a measure. When it's just free conversation, is 5 minutes enough? And there is the generalization problem. SLPs noted that life practice was often limited and artificial, leading to therapy tasks don't always transfer to real life. Let's hear what Emily had to say. I sometimes get concerned that we are not giving people tasks that actually generalize to real life. If you play Nintendo Wii, it may make you play a very good game of Nintendo Wii tennis. You may not end up at Wimbledon. This is the gap, turning goals into structured, sustainable practice. Let's turn to internal factors, the personal abilities that shape long-term outcomes. SLPs and families pointed to 4 common barriers: executive function difficulties, low motivation, mental health issues, and aphasia severity. Our data shows that personal abilities are a spectrum. Clients usually have a mix of abilities, and who maintain better? Younger clients, self-motivated, confident, proactive, engaged in meaningful activities. But barriers hinders maintenance. Low self-esteem, mental health issues, cognitive problems. This limits communication and hinder maintenance. And this brings us to a crucial factor, the link between executive function and self-regulation. Think of executive function as cognitive toolkit. It is helping people to plan, start, stay on task, solve problems, and self-monitor. Self-regulation is the active process of using the toolkit to maintain goals. This is especially important when things get challenging, like managing a communication breakdown. But here is the problem. Stroke often impact those very cognitive systems. That is why unstructured practice, which is what most real-life situations are, becomes incredibly taxing. It demands planning, initiation, persistence. This helps to explain why so many clients struggle to maintain gains, even after successful therapy. The cognitive load is just too high without support. As one SLP puts it, I think there is also sometimes this component of cognitive impairment and difficulty with initiation and organizing things that makes it hard to maintain that. People with aphasia often rely on partners to plan, coordinate, and keep things going, not by choice, but because they have no alternative. Without executive function support, self-managed maintenance is nearly impossible. Executive function isn't the only barrier. Mental health matters just as much. Depression, anxiety, low confidence, embarrassment are major obstacles. Communication breakdown often trigger frustration, fear, anger, which lead to avoidance. And one partner told us, his emotion affects his speech so much. The minute you add irritation, anxiety, sadness, they all affect his speech. And over time, motivation fades, especially when progress is slow. Who maintain better? Those who are optimistic, proactive, and internally motivated. But not everyone has those resources. We've seen motivation is crucial, but what is exactly motivation? It's the drive to keep going, the intention to maintain behavior. Our study found motivation is a key. It's drive for active behavior and compliance. But here what matters. People motivated by values or interests stay more engaged, confident, and persistent. During therapy, behavior change is driven by external motivation. What does this mean? Visible progress, structure, SLP support, feedback. But once therapy ends, the structure disappears, the clinician is gone, the routine is gone, and with it, motivation may fade. Now, responsibility shifts to the person with aphasia and their partner. But to maintain gains, they need strong self-regulation skills. And we already know that executive function is often impaired after stroke. This is where internal motivation plays a vital role. When activities feel meaningful, enjoyable, and tied to identity, people are more likely to continue. Why is this important? Internal motivation can bypass cognitive barriers. Enjoyable activities are easier to repeat. They become routine, which require less planning and effort, and that is the path to long-term maintenance. But while internal motivation provides a drive, the way is often blocked. The missing piece is what we identified as crucial knowledge and services gap. What really happens after discharge? People with aphasia often expected continuing improvement, not realizing that gains could plateau or decline. Partners were more aware of this risk, but both lacked the knowledge, skills, and support to maintain progress. Most received only a generic advice, keep practicing, with no personalized plan or real-life strategies. They were left to manage this phase alone. Mike, a partner, told us, I've got no skills to deal with whatever Kathy gleaned from the trial. Kate, a person with aphasia, said, I didn't know what would work. What can I do? These quotes reflect a shared experience, lack of knowledge, skills, and support. Without professional guidance, many slipped back into unhelpful routines. Additionally, most SLP worked with subacute clients with little exposure to chronic cases, and long-term services were very limited. No follow-up, no booster session, no clear pathway. Both clients and clinicians lacked the tools to support maintenance. As one SLP puts it, I'm now the last person in the line. I haven't got anywhere to hand them to. I've got an aphasia support group, but I haven't got anywhere else. And this reflects what many SLPs shared. After discharge, there was no clear pathway for long-term support. And the results? Frustrated clinicians and people with aphasia still needing help. The system couldn't meet ongoing needs. So who stepped in? Of course, partners and family. But they faced major challenges too, as you will see. So partners stepped in to fill the gap. Both studies found that external support was essential for maintaining gains, especially for clients with severe aphasia, executive functions difficulties, or mental health issues. And what did partners do? They become communication enablers, organize activities, support daily interaction, kept motivation going. Many took a therapy role at home, providing reminders, encouragement, and feedback in the absence of professional input. And this support often made the difference between progress and decline. As SLP in our study recognized this, it's that home support. You feel sorry for the people who don't have that partner or friend. It's just a huge barrier. However, most partners receive no formal training or guidance. Partner support was essential, but not always helpful. Some spoke for the person with aphasia, others pushed too hard or used unhelpful strategies. Support was well meant, but often missed the mark. This brings us to professional support. Participants valued SLP guide therapy, especially personalized goals, motivation, encouragement, and structured feedback. As Jerry, a person with aphasia, said, it's effective because I've got the feedback. Feedback gave meaning and motivation. It is what made therapy irreplaceable. They believed more therapy could boost and sustain gains. However, professional support is limited in the chronic stage. Therapy often ends at the discharge. No follow-up, no ongoing guidance. And clients and partners were left on their own, relying on self-regulation, which we know it's a major challenge when you have executive function impairments. So what is needed? We need something for less effort and more sustainability. Habits and routines are that support daily communication. So we've identified the barriers. Now let's shift to a part of the solution, habits and routines. Why habits? Because they address the core challenge, maintaining gains without relying on high cognitive efforts. Behavioral research shows habits are easier to maintain than behaviors needing ongoing self-regulation. But maintenance relies on executive functions like planning, initiation, which are often impaired after stroke. That is why many efforts fail. Habits offer a solution. Once routines are formed, they need less effort, less planning, they become automatic. In familiar, supportive setting, habits are even easier to sustain. That is how we overcome cognitive barriers. So what did we learn overall? Both studies revealed a complex picture. Both groups identified similar challenges, but they saw them through different perspectives. Both studies highlighted the similar core themes: abilities, service gap, daily use, and support. But SLPs saw this clinically, clients and partners felt them personally, and we need both views to truly understand maintenance. So how do these factors interact? These models show what supports maintenance in chronic aphasia. At the base is the foundation. Real-life communication depends on having enough meaningful opportunities. In the middle circle are key enablers: knowledge, awareness, and support. Clients must understand that gains need to be maintained. Positive support at home, access to services, and a familiar environment all increase the chances of success. At the center are the internal factors within the person: motivation, beliefs, emotions, executive functions, and habits. Together with aphasia severity, these shape whether gains are maintained or not. So now that we understand the complexity, what can clinicians actually do? So the first thing is raise awareness. Clients and families must understand maintaining gains requires use, like any other skill. Without it, decline is likely. It's not a failure, it's just how skills work. We need to be transparent about the limits of intensive therapy, and we need to set with them realistic expectations very early. Additionally, we need to create real communication opportunities to link people to interest-based daily activities before the discharge, not only aphasia groups. And we can't leave it to the person alone. Clinicians must actively assist. We need to focus on what matters to them, to the people with aphasia. That is what drives motivations and maintenance. And prepare partners, help them to create and reinforce daily routines. And the goal is to turn communication into habit, structured, meaningful, automatic. And individual efforts are not enough. We need models of care that include booster sessions, scheduled follow-ups, ongoing clinical contact. Aphasia, like any other chronic condition, needs long-term management. Clinicians need training in maintenance, habit-based frameworks to reduce cognitive load, community of practice to share what works, because without a system for maintenance, we will keep losing the gains we worked so hard to achieve. When I began this work, my goal was to shift how we think about success in aphasia rehabilitation, not just the short-term change, but lasting impact. And it's very encouraging to see real progress. Maintenance is now visible in trials, embedded in the Australian aphasia rehabilitation pathway. MDC benchmarks are used in research, and more outcome tools now have published MDC valued clinicians can apply. There is still much more to do, but we are moving toward a future where long-term maintenance isn't overlooked. It's central to how we define success. So what is next? We need to validate MDC values for all aphasia tools across languages and recovery phases so that meaningful change is clear and easy to use in the clinic. It's exciting to see that the field already moving in this direction. In the chronic stage, impairment doesn't tell the full story. We need to shift focus from what is broken to what people do. Behavioral factors like motivation, self-regulation, skills, and habits may be a key to maintenance. Until now, therapy success has focused on immediate gains, but short-term change doesn't guarantee long-term outcomes. In this work, we aim to shift the focus. I hope maintenance will become a core goal and a key measure of success in aphasia rehabilitation. Therapy should aim not just for progress, but for progress that endures. Until recently, maintenance was overlooked in aphasia research. This work helped change that. It laid the foundation for understanding long-term challenges and introduced new outcome framework, now used in trials to define what success really means. Our study showed clear group level gains from intensive therapy, but only 1 in 5 maintained those gains long term. That is the real challenge, not just getting better, but staying better. So what supports long-term maintenance? From what I've seen, it's never just one thing. It takes a mix: motivation, executive function, skills, knowledge, support, all working together. And why does this matter? Because maintaining gains isn't just about language, it's about life. So what now? To improve outcome in chronic aphasia, we need long-term, person-centered care models that support sustained, meaningful communication. And before the question time, I want to acknowledge the important contribution of the people on this slide to this work. Thank you very much. I would be happy to answer any questions you may have. Also, if you are watching the recording, please feel free to reach out and email me if you have any questions about this work. Thank you.
Thank you so much, Maya, for that. It's a pretty challenging problem that I know you've tackled over the years of your PhD and since. And yeah, it's pretty complicated, right? But you've made some pretty good inroads.
It's very complicated. It took me a while to understand it myself.
Yeah, even conceptually. So I mean, that's a contribution just there. So I encourage people to add some more questions to the Q&A. And before I get to them, I just had one of my own. So one of your participants said they didn't know what would work. They didn't know what to do. And I know that was like a stroke survivor, but I bet a lot of clinicians feel like that too. So you've outlined some resources there, but is there anything else you could say about the blueprint you referenced that you're developing?
Yes, so because maintenance is something that, was under research, we decided to develop like a blueprint to say what you need to know about maintenance. So if someone wants, they can reach out, and I'm happy to, speak about that, and maybe we'll see how we can contribute to the knowledge about maintenance, because I think it's really useful to understand all the behavioral theory around maintenance, and we can learn a lot from other areas, not just brain damage, but also, we're all trying to maintain things, and the same principles works, but much more difficult.
Yeah. Question from Katarina Breitenstein. Thank you, Maya, for this clear, informative presentation. Do you think immersive interactive environments with tailored everyday communication scenarios and AI-mediated feedback are the future in promoting cost-effective access to communication opportunities and thus maintenance after therapy? So I guess sort of VR environments and talking to an AI persona?
I think it could be a starting point, but I think that you need to leave it in an environment that actually you tackle problems, because the unstructured environment actually causing you to the need to manage your to actually to solve problems all the time. So every time a person with aphasia has a communication breakdown, they actually need to solve it somewhere somehow. So I think that if we are doing something like AI, we will need to train them really good about issues that could come up. And I think that is the reality of real life communication. You can't predict it really well. And this is why there are no rules in the environment how you can respond to something. It's really, really difficult, but it's a good
Mm,
idea to explore.
yeah, and I guess, AI is very happy to misunderstand you or to just be confused. Like it's a lot more easy to communicate with a bot than a real person.
Definitely, definitely. They really want to, the bot is always trying to say you are right, but in the real world, you know, it's not the case, and
Yeah.
not everyone are nice and happy to be patient.
Mm,
It actually really depends on the listener, how
yeah.
if they are patient, if they are willing to hear you. Yeah, that's something.
Yep. Annie Hill said, thanks, Maya, for shedding light on a complex area of both clinical practice and research. Given the impact of cognitive and executive function on the motivation needed for engaging in maintenance tasks, do you think we should be working in a multidisciplinary manner to optimize maintenance in people with aphasia and care partners? If so, what would that look like? Or what would your ideal maintenance program look like?
Wow. A very big question. Yes, I think that we definitely need to work with other, professions. And I think the collaboration is, it's something that will add up to the results. Like, OT and,
Mm.
but not just. Um, and what was the other questions?
Um, what would the ideal maintenance routine look like, schedule look like?
I think it's again, if it could be something that you are enjoying and you can do every day, and you had multiple opportunities to speak during the day, and you enjoy doing what you do, I think that is the ideal maintenance program.
Mm.
So the real practice, the real life is the practice, like any other skill we use. The use it or lose it is, it's like it's really simple at the end. You need to do something that you find um, enjoyable and something that you love doing. And this is why I think that people with aphasia need more places, more environments that they can speak.
Yeah.
Sorry.
And I guess that's why, as you pointed out, it's better if goals and therapy are built around the tasks they enjoy doing rather than trying to build maintenance tasks around the therapy they've already done. So it's,
Oh, for
making it.
sure. But it's really challenging. It's not that easy. And I think that currently we don't have enough time in the clinic to try to
Yeah.
understand, and relying on families also, it's not a good idea. And actually research show that the agreement between what the person with aphasia wanted and what family thought that he wanted are not that good, which is also problematic.
Mm, yep. I'm sure there's lots of people on the call agreeing with you that there's not enough time. Katie Stewart said, how do you think advocating for funding for aphasia maintenance would work with NDIS funding and aged care support at home. I'm not sure if you're familiar with those programs, Maya.
I'm familiar with NDIS.
You are? Yep.
I think that at the end, if you have better communication, we know that people who have better communication will spend less time in hospital, and we know that if you can communicate things, your quality of life is much better. I think that we need to tackle it from that areas and actually show the system how it's saving them money, because it's unfortunately it's always about money.
Yep. Question from, excuse me, Winona Gardner. Thank you for your presentation. This is a passion area of mine. Do you see a future where we create a guideline or map of the next steps post-discharge to maintain therapy? Do you see potential for communication partner training to evolve to include more information about the concept of maintenance?
I definitely think that we need guidelines for that. And definitely, most people with aphasia live in the chronic stage. What they do is maintenance all the time. All our energy is now on the subacute phase, but what we truly need to do is to shift our focus to the chronic stage. Regarding the partners training, I don't know. I think that this is something that of course, you need to include, but it's sometimes the interaction between the partner or between the family. And I think it's going back to the relationship before the stroke, sometimes, and also after the stroke. And I think here we need people that to work with psychologists and social workers. And for sure, this is something that we need to look at, how we help everyone to manage this atmosphere, which is really not easy for everyone.
Yeah, every couple or dyad is a bit different.
Yeah.
We might have time for just a couple more. So Jessica Clue said, did you find that those patients that had barriers such as embarrassment, anger, reluctance to engage, or were just introverted, did they need extra help or different help to those that have more sort of internal motivation?
I think sometimes it's coming from the inside. I think sometimes the difference is executive functions. I think it matters a lot. And there is research that executive functions actually, important when you have successful therapy or not. And I think cognitive issues are doing a lot of damage when we look at this area. So I think that's the thing. And sometimes you are just more a proactive person, but not just. It's not just that. It's a mix of things.
Yep. Well, on that topic, Meredith Johnson has asked whether there's a screening tool or checklist that exists to evaluate the presence of those factors you identified as critical for maintenance.
There is something that I created during the PhD.
Yep.
I can share that my mom had a stroke. It was subcortical, and she has executive functions issues. And I can tell you that, and she has language issues. And yes, I have something like that. And yeah, I'm happy to discuss that if anyone's interested.
Okay, sounds like nothing published, and so therefore you had
No,
to make
it's not published.
make it something.
Yeah.
Yeah. Well, it's the first step then.
Yeah.
Kathleen Mellon said, we know that people with aphasia tend to have fewer of these incidental daily opportunities for communication from very early on post-stroke during hospital admissions. Should clinicians work on increasing this interaction in the acute and subacute phases, as well as consider it in chronic stages in order to support that longer-term maintenance and motivation?
Definitely. And one experienced clinician actually told me that what she's doing before the discharge is actually replacing the therapy in like therapy activities. Like she went with the client to the gym, so we will have opportunity to work in the gym and to speak with someone. So you need to consider what a person likes to do and try to do that from early stage, definitely. And also, if you see risk for avoidance of speaking or depression, we need to handle it, as soon as possible, because we don't want to have unwanted habits, which are much, much harder to break longer, later.
Yeah. Yeah. Once it's entrenched.
Yes.
We've got 3 minutes and 3 questions, so let's see if we can do it. Kay Stewart said, I'm really interested in speech pathology's routine-based interviewing, so embedding opportunities into routine. Any advice on any tools?
Oh, nothing that comes up in my mind right now, but send me an email and I'll try to help.
Hmm. Sarah Martin said, thank you, Maya, for giving us so much to think about. Your talk is inspiring. Do you think there's a place for working on executive function, for instance, via goal management training?
Oh, I definitely think that yes, there is things that we can do, like to plan ahead. What do you do once you have a breakdown? You can guide, the people around that person, how to assist him when there is a problem. Definitely, there are action plans that we can do. And yes, definitely, there are things that we can do. And definitely, this is something that we can work on that, on executive
Mm.
functions. It's not easy, but it's possible.
Last question, Lillian Krikeli. Thank you very much for this presentation. Maya articulates the problem of maintenance so beautifully. So applicable to areas beyond aphasia. I'd be curious in a future presentation to know your thoughts on goals, goal setting, possible motivation, or interviewing even, especially for NDIS clients where the goals that we are writing can sometimes feel contrived or very tick box exercises.
Uh,
So applying it
so
beyond aphasia, some of those goal setting and goals principles,
I
applying it to
think,
other.
yeah, yeah, for sure, those goals go beyond just aphasia because you can impact quality of life, participation, and people with aphasia wants to be meaningful, and this is a way to make them feel better. Like, let's say that they will do cooking classes, or they will participate in activities in the community, like one clinician spoke about a filming course, or if you go and learned graphics. So it could be, you can tailor it for work maybe, or for volunteering. So again,
Mm,
it's also, of course, it's go beyond aphasia alone.
yep. Well, thank you again, Maya, for your time and for your presentation. I know there's probably a heap more questions that we won't get to today, unfortunately, but as Maya said, please feel free to email her um, if you have more questions. Today's seminar has been recorded and will be available in the next few weeks on our Aphasia CRE YouTube channel, and you can explore our other videos. I think this will be video number 60, so there's plenty there to look at. To stay connected, you can follow our blog or Facebook or our LinkedIn page, where we regularly post updates on research, studies, and opportunities to get involved. Next month, we'll be hearing from Kathleen Mallon, When Care Gets Lost in Translation, Clinical Pathways and Outcomes for People with Aphasia Who Need an Interpreter. That'll be on 26th of November, and we will let you know the time shortly. Thank you, Maya. Thank you, everyone, for attending. See you next time.